For those of you who are interested in being HoLEP competent, it is a special interest module thing, if you like. This has changed, so don't take all of what I've written here. This is now changing for other special interest modules. But for the advanced general urology, additional BOO procedure level, PBA competency level 4 is what you're looking at for HoLEP. And that's two trainers signing you off at level 4. So not only do you want a department that has HoLEP, but you actually want two trainers who are delivering it so that there's two people who can sign you off as HoLEP competent. So this is what Ananda asked me to cover. Indications, learning experience, literature on block versus incisional technique and kit. When you get tired of me talking, tell me to stop. Indication, well, EAU guidelines for LUTS. This is it. This is that one-liner, offer HoLEP to men with moderate to severe LUTS as an alternative to TRP or open prostatectomy. Interestingly, AUA take it one step further. So this was amended published in 21 and amended in 23. And what is said here, it's a size independent option for treatment of LUTS or BPH. And a lot of departments are sort of giving a cutoff of 80 grams because of the sheer numbers of HoLEPs that are being done or that can be offered, if you like. So because there's not many people doing HoLEP, just from the experience of my department, it was very much kind of the bigger prostates get the HoLEPs, but you can absolutely offer it to the less than 80 grams. It is a size independent procedure, and we do that. So just my HoLEP experience. So this is how long ago it was. April 2011, I went to a laser safety course because that's what you needed to get, a tick box to say you've been on this course. And at that course was Tev Aho showing what a HoLEP was. And I was sold on HoLEP at that point. But never, it was a it was a video that he was showing. So it wasn't, I think it was in Cambridge, and he was operating somewhere. It was live streamed to the lecture theatre. Since then, I've been as a consultant. So that was just a couple of years before consultancy. Then now as a consultant in 2016, went to HoLEP Masterclass, and then went to Spain as well to watch it being done live. So what was my journey? It was the mentorship approach, where it's not quite see one, do one, teach one, but you might get a little bit amused by someone who, Ali Henderson, another consultant in Maidstone, came to watch me. So I'm a consultant. I've been a consultant since 2013. So he came, we got the kit, he came, watched me do 3 cases. He did have an honorary contract, so he would scrub in occasionally, but literally just left me to it. Came again in November. Cases got cancelled on the day, so it was just 1 case on each of those days. And then that was it. Off I went. And it was very slow. So it was very slow, 2020. So you could think it was going to go up like this. But 2020 was a blip because of COVID. But yeah, it did sort of take off. And now this is my operating list capacity. My list is just full of HoLEPs, basically. But this is where I am now. So the literature, I'm not going to go through every bit of all the papers on HoLEP. There'll be a lot. Just wanted to sort of highlight 3 papers, I think it is, or maybe more. So what's the learning curve of HoLEP? Is it really kind of that mentorship model, if you like, of select very carefully the cases, do them with a mentor present, and then slowly build up your practice. This paper talks about 25 to 50 cases to get to competency. But for those of you who are here interested, you want to be looking at a department who is offering HoLEP with those numbers, really. Chronic retention, that question of patients with chronic retention, not high pressure chronic retention, but we tended to do urodynamics on them to see if they've got good detrusor contractions before deciding, yes, let's give them some sort of bladder outflow surgery. And this paper by Tevajo basically concluded with, excellent catheter-free rates for the chronic retainers who were not selected by urodynamics. So basically, if you enucleate the prostate, give them a good capacity, whether they have detrusor failure or not, they're going to pee. So offer HoLEP. This is a paper by Amy Cranbeck and her team, and they've published quite a few papers now on same-day discharge. And that is same-day discharge after HoLEP, but taking out the catheter on the day of the HoLEP. So this is not, so GERFT is pushing all of us to deliver day case bladder outflow surgery. So you'll no doubt listen to Resume, Aquablation, Urolift today, but you can ask them how many of them are sending their patients home without a catheter, with a great success rate and with time and sort of longevity of that procedure. So here we go. This is Amy Cranbeck saying, talk on the day, 87% of patients voiding. And this is going to be presented at our meeting this afternoon. We are starting to do same-day TWOC, and when we get brave enough, and we were brave enough for 39 patients, 32 of them passed their TWOC, so that's an 82% success rate. 7 didn't, but they've all voided on their second TWOC. So really trying to drive day case bladder outflow surgery, but HoLEP can absolutely deliver on that too. So what are the techniques? And I was trying to find pictures here, and I found no pictures to kind of explain my thoughts. And I thought, oh gosh, I'm going to get stuck using my hands now. So I'm sorry, I'm going to use my hands. I was thinking of whether I should put a video clip, but the video clips are so long. I'm not like the HoLEP surgeons who can finish quickly, though my registrar said, but Ms. Nitkunan, you did this in 27 minutes yesterday, but that's a rarity when the prostate is really small. So, usually it's about 1.5 to 2 hours, and I'm sure you don't want to sit through that. So what's en bloc versus incisional? So en bloc is marking or scoring the apical mucosa sort of over the viru and around sort of just proximal to the sphincter. So as you're going in, see the sphincter, go in, score along there, release the mucosa, and then find that plane and develop that plane. And you are en bloc, going circumferentially around the prostate to using the laser to slowly push that prostate then into the bladder. So that's en bloc. Incisional is making cuts. So if it's a tri-lobe incisional technique, then it's a 5 o'clock incision, 7 o'clock incision, cutting in front of the viru and then pushing the middle lobe in, and then again scoring on the in the apical mucosal release and doing a 12 o'clock incision, and then you release the left lobe and then you release the right lobe. So that's your 3-lobe technique. So it's an additional 5 o'clock, 7 o'clock, and 12 o'clock. And then there's, of course, the bilobe technique. So sometimes 2 lobes are fused. You then just do one incision, so 5 o'clock maybe, and the 12 o'clock. So all of this, the left comes off in one go, and then maybe the middle and the right released in one go. So you can have en bloc versus incisional techniques, and then the incisional technique can be 3 lobe or 2 lobe. And I know the 2 people who have played with this have done a bit of en bloc. I don't know what technique most of you have seen, whether that's en bloc or incisional. I move from 3 lobe technique. So I was very much a YouTube watcher, and I started by watching Tev every night. My children knew if it was a HoLEP day the next day because I would watch a YouTube clip on HoLEP, and it was always the same video clip. It was Tev Aho's 3 lobe technique. And then one day my registrar was watching me and said, why are you doing that? I went from 3 lobe to 2 lobe and then got nudged into doing en bloc. And once I've done en bloc, I haven't looked back. It's en bloc for everything, even the largest, which was a 300-gram prostate. So even 300 grams en bloc. So which one should you do? And the evidence is going towards en bloc. So it's the enucleation efficiency. If you think about it, doing 1, 2, 3 cuts is more than just the early apical mucosal release. So you're doing 3 more cuts in an incisional technique than an en bloc technique. So that's where the enucleation efficiency comes into it. And again, 3 lobe, another study looking at 3 lobe en bloc technique and 3 lobe technique and en bloc technique, twice shorter enucleation time is what they were quoting, and this was last year. So what's my way, if you like? So I've already alluded to it. I kind of call it a takeoff, cruising, and then landing. So the takeoff is the early apical release, so that marking and scoring. So therefore, there's no tension on the sphincter mucosa anymore, so that you can then relax about it. And the cruising bit is enucleating. The plane is always easiest to find just lateral to the veru. So nowadays, if you start to look near the veru, you will sometimes see a little dimple or even just a little plane that already starts to show itself as soon as you incise around that veru. So I tend to incise that way and up, and then find this plane, and always easier to find it more proximally, so going that way rather than here, because just like you get the bladder neck fibers, there's fibers here that sort of demarcate the line and are a little bit more sticky. So finding the plane is more proximal than distal. So finding that plane, that 2 o'clock to 10 o'clock, always the tricky bit. And that's because that's your anterior fibromuscular layer. So you have to cut. There is no nice plane to just separate the tissue. So I tend to enucleate right up to 2 o'clock and then do the same for this side. And then 10 to 2, I'm sort of joining the dots, if you like, and finding that plane at the top. It's just the initial bit, which is pretty interesting, shall I say, at the top anteriorly, and then the rest of the enucleation should be fine. It's key to stay in the plane, trying not to go in between nodules as well. And then the last bit, which is the landing, is I release at the bladder neck. So you've enucleated everything and you've just got the bladder neck. So you just start to divide the fibers at 12 o'clock, and you're dropping down all around the bladder neck, all around this way, all around this way. And then I have what I term is a U. So you're thinning the U and shortening the U. And then the whole thing goes into the bladder, and then more morcellation. This was the case that I described and then showed a video at the HoLEP course for consultants and trainees in July. But I'm not showing and sharing the video. But just a case, 71-year-old IPSS quite high with a significant bother on tablets, PSA okay, MRI 170 grams, performing CISC, and that's his flow rate. That was the CT sorry, that was the MRI, that was the CT, and that got enucleated on block. These are my settings, and I do have a registrar who's with me, and they absolutely would be doing a degree of the HoLEP as well. They tend to start with the morcellation and then going backwards, if you like, hemostasis and then enucleation. This chap had stones, so kind of the beginning and the end was where the registrar was involved. This is the kit. So laser machine. So I have used Luminous 120, CyberHo 100 and CyberHo 150 when got the CyberHo 150 when our CyberHo 100 just decided to break down for a bit. So I guess it's knowing what settings. Moses or pulse modulated, I didn't share that literature, but there's thought that it gives better hemostasis, less laser defragmentation, so or laser fragmentation, where the laser keeps fragmenting, and so you don't get an efficient cut. Knowing your kit, so we have Stort's kits and the Stort's nephroscope, being able to, like anything endoscopic, being able to put this together blindfolded sort of thing. You need to know your kit. This gets put together. So that's the outer and the inner sheath. And this is inserted into the patient and then replaced. So with the irrigating scope remaining, inserting the Kuntz working element, which is where the laser fiber goes through there, to then do your enucleation, and then keeping the outer sheath, putting this nephroscope in so that the morcellator can be put straight in. And of course, during morcellation, 2 lots of irrigation is running, and this is the morcellator. So I use this one, which is Piranha. But of course, there's other kits. There's the Genius morcellator, which I haven't trialed, hoping to at some point, but I haven't trialed yet. So how to train, for those of you who put your hand up and said, I want to do some HoLEP, I guess know your trainer. I do feel that a lot of consultants, maybe I'm wrong in saying this, are still on their learning curve. Therefore, how do you learn whilst they really don't want you touching the patient? Because you haven't had that joy yet, or you may have, of trying to get someone out of a problem. And it's always better to just stay in the plane and know you're in the plane rather than trying to find the plane when the plane is completely lost. So really working with your trainer to figure out how much they will let you do. What I call is educational brief. So after the team brief, speak to whoever's there as your educational brief of what do you think is realistic, of what can I achieve? Can I at least do morcellation today? Of course, that whole thing of if you don't know your patient, don't even bother talking to me because you're not ready to do this theatre list. Know your kit. You can go through the kit with your trainer, with the scrub staff, really get to know your kit and being able to troubleshoot your kit. And as I said, start with morcellation and then enucleation. It's how long can I hold my nerve, really? So I say time me, 15 minutes on, 15 minutes off, as in 15 minutes for me, 15 minutes for the registrar. That keeps us to vague time as well, because we are under pressure to do cases in theatre. And then the last bit is the releasing of, second last bit is releasing the bladder neck fibers. And then the last thing I let people do is sort of that early apical release, because I really want to make sure that they're going nowhere near the sphincter. That was it. Good luck with your HoLEP journeys, and happy to take any questions from anyone.
Thank you, Tharani. That's quite clear and succinct. Any questions?
One question, sorry.
Yeah, go ahead.
I mean, the last talk was about aquablation. So, you were saying it's that it's the same effective as HoLEP. It's quick and the same results, and even sometimes better. Quick procedure, easy to learn. So it's good to hear from other side of the story. What do you think as experience with plastic surgeons about aquablation?
Sorry, what was the surgery that you had a discussion about?
Tharani, I'll repeat, I'm closer to the mic. So
Yeah.
Today we are discussing all the energy modalities. The guys have already heard about aquablation. And in the talk, it's discussed as if like it's absolute replacement for HoLEP. And so the question is, what is your take on aquablation versus HoLEP?
Yeah, guess what? We're having that talk in our Southwest London BPH meeting this afternoon. So I'm going to get educated too. But my question is, what is the long-term data for aquablation? So maybe you know the answer already. So if you're counseling a patient and you want to tell them that this is going to last you for blah years or blah years. So we quote a redo rate for HoLEP at 1% at 10 years. So if you're the bloke, your chance of needing another bladder outflow procedure, HoLEP procedure is 1% at 10 years. For TRP, it's quoted at 10%. So my question back to you is, what is the aquablation rate, and do they actually have any of that long-term data? What's the longest long-term that they have for aquablation at the moment?
Yeah, I can also bring in an example like Tesla automated diving car. We don't have that permission yet in UK, but say for example you are in US and you have that facility. Of course, driving a good higher-end Tesla is a pleasure. But what happens if you are able to do hands-free and let the car drive on its own on a motorway? It's almost like that. You will be missing a good pleasurable part of your career if you are directly jumping to aquablation without traveling through HoLEP.
You know, I accept that this is also I was thinking that, you know, I'm so pro HoLEP, which is terrible, I know, but my thoughts are can everyone, one of the things I was thinking about and reflecting on is, can everyone learn HoLEP? And why is it being considered as such a difficult procedure to learn? You know, if I can do it, surely everyone can do it. And what is the issue? To me, it's you have to be focused. You have to say, I want to learn HoLEP. It is a skill set. Someone said to me yesterday, this is a radical prostatectomy surgeon. He said, HoLEP is more difficult than radical prostatectomy. It's like, why? Why is that? Why are we not capable of training and teaching HoLEP? To me, you've got to be focused to learn to do it. So even if you're not watching many or doing many, you have to keep your head and your eye in. And there's another paper somewhere that talks about doing one HoLEP a week to keep that learning curve steady. So even if you're not doing them, even watching that YouTube clip on ×2 speed might keep your eye in.
Or the ×2 speed will keep your speed also a bit higher in real time. Reflection. Any other questions? Tharani, are you okay for one more question?
Of course.
Yeah. What about the different choices of modulator? You said you are happy with stores, but because that is one of the main safety remit, isn't it? What is your choice? Say,
So,
for
so
example,
I use Richard
start
Wolf.
from new.
Yeah, so I use Richard Wolf, which is Piranha. Okay, the actual kit is Storz, but the morcellator handpiece, the machine is Richard Wolf, and it's called Piranha. We had a luminous morcellator before that was really clunky, heavy for me as well, and the morcellation efficiency was poor. So luckily, because it broke down a bit, we were able to get the Piranha, and the Piranhas worked for us brilliantly. The Genius morcellator on the HoLEP WhatsApp group, there's a lot of chat about Genius. And one of the things is the fact that you don't have to keep changing those water canisters and things, and that it has good efficiency. I am yet to see those papers comparing Genius with Piranha. I don't think you should compare with Luminous anymore. It should be the Genius morcellator with a Piranha. But I haven't seen absolute data for that.
Thank you very much. Any other questions before we break? Thank you, Tharani. I will be collecting feedback a bit later in the day. I will share it with you, and we really appreciate your time. Possibly next year in the BPH Masterclass, we'll be able to host you in person, and we love to have you in Birmingham.
That'll be lovely. Thank you very much. Have a good day, everyone.
Thank you.
Thank you.